so let's start the webinar, Telehealth 101. This is the most common question I get asked in the field. What is the telehealth versus what is telemedicine? Telehealth is use of electronic information and telecommunications technology to support long-distance clinical health care. Whereas telemedicine, which allows healthcare providers to evaluate, diagnose, and treat patients over video visits. There are several types of telemedicine. Asynchronized, where there are exchange of still images, text, phone calls. And the other type is synchronized, which is more like a video visits. There are several companies like My Telemedicine, On Doctor Demand, which provide this kind of services. There are several benefits to have this third party, provides the accessibility of information, but then also it contributes to the fragmentation of patient care. So the second kind of synchronized is practice-based telemedicine, where practices sees their own patient. And the new one, which there's a lot of talk going on, is remote patient monitoring, which is another huge topic, and we can have like another webinar on this topic. What I see in the field is telemedicine is becoming is on rise. Why telemedicine? Why do you think about this? What I see in the field is that telemedicine is becoming very popular, especially among the younger population. Consumer wants it, and for several practices, it may help to tap in a new market. It can help to improve the revenue. For example, some use cases like some diagnostic test reviews, follow-up from acute conditions, or pre-operation counselings. Certain cases can be considered for telehealth or telemedicine, and which can add to revenue. Increase access to care, especially think of older population who does not have access to transportation, or if you are traveling and if you're sick and you want to see your provider, that's a good place for telemedicine. Some studies shows that it has also reduced no-shows. There are several studies which talks that telehealth has also helped to reduce urgent care visits and hospitalizations as well. Improve clinical outcomes, obviously, for face-to-face is better than phone. Work from home flexibility. This is a very interesting one, especially for the providers. They can work from home. I have a next door neighbor, she is MD. She works from home 24/7 doing telehealth. She is licensed to see patients in 36 states. She doesn't even leave her house. So I thought that's very interesting. I never thought providers could do that. Improve patient satisfaction. Accessibility of provider or care team really helps with the patient satisfaction, which in turn can help with patient retention. So those are some good benefits. Challenges. As we all know, challenges are always huge than the benefits. Craig is going to go in detail about the technology-related challenges. But what I see as a practice facilitator, what I see in the field is the biggest confusion, which patients are eligible for a video visit, which are not. EMRs are doing pretty good job of having those on the banner, but still it's a challenge. And with the time, it's getting better. So before we go into further detail, a very high level of telehealth payer landscape. Let's talk about Medicare fee-for-service. As we all know, Medicare is always makes the thing a little bit difficult. So they have very limited coverage, and Lori will go into the Medicare fee-for-service requirements and billings. Commercial insurance. Those who have a huge population of commercial insurance should consider this. Just think of a case scenario. If you do 100 video visit, and if you can reduce one hospitalization, the cost commercial insurance can save. In a lot of states, commercial insurance do cover telemedicine. It's a good market to tap into. Medicaid. Medicaid is different from state to state, so please do check with your state about Medicaid patients. Cash. This is an interesting one. Especially what I see in the field is that for peds, parents find it much easier to just have a video visit and pay cash. Or a Medicare fee-for-service population, because the cost is not that high per visit. So instead of arranging a transportation, going to the office, some Medicare fee-for-service patients don't mind paying cash and agreeing for televisits. So those are some benefits and two things to consider. Next, we will let Lori, who is our Medicare fee-for-service expert, she will talk about very specific about Medicare fee-for-service patients and what are the requirements. Thank you, Lori. It's all yours.
Thank you. Thank you, Seema. I want to thank Comagin for facilitating this presentation today and for having me here to speak. Again, I'm Lori Weber, an education rep for Noridian Fee-for-Service Part B Medicare. So we're going to go over some of the telehealth services. For those of you that may have never seen the Noridian home pages, we do have complete information about telehealth and a more in-depth telehealth presentation. But for today, we're just going to give you a high overview of what telehealth means to Medicare. This is a disclaimer that we put on all of our webinars and seminars that this is an as-is product. And for those of you in the Medicare billing world, you know that things can change. So we just ask that you keep updated by signing up for our listserv emails and attending webinars like this. Oh, excuse me.
Back. You have to go back. Hold on. Which one? No, don't do anything. No. You're left. Back. Why is it not going? Sorry, we are having some difficulties with our slides.
Oh, it does not want to go back. 1 second here.
Okay, we have our expert here helping us with our slides.
Sorry, we're having some technical difficulty. So while we're getting that fixed, as Seema already presented, telemedicine can be quite different from Medicare's telehealth. So we want to make sure that you understand that difference and how we have a lot of different rules and regulations that need to be followed.
You know where to start? Noridian, the number 8.
And then the next.
No, actually, you can do number 9. Okay, sorry for the technology.
Very weird. Okay, well, it keeps wanting to jump, and I'm going to do our best to see how we can get that. I don't really know why. And I apologize, everyone, while it's being a brat. So,
Can we go to the regular mode and we can talk about, she can see the slides. Go to the other view.
okay, let's get out of here.
Okay, go to slide 11. And we can just keep it like this until we reach to slide 11. Okay. No, slide 10. Okay, and then we can do it individually. Sorry, everyone.
Okay.
Okay, let's leave it.
So here we go. So as you know, at telehealth in Medicare, it's real-time communication. And that means with both audio and video that's HIPAA compliant, and it's between eligible practitioners and or physicians, and also eligible beneficiaries. And we'll talk about both of those in more detail coming up. You do need to have a telecommunications system, and this is to substitute for that in-person encounter. The patient must be present and coherent and participating. And the way that patients or beneficiaries are approved is through the rural zip code, and that's where you'll see some of these slides coming up. They have to be seen in an approved originating site. And so what we allow is the same thing. There are several codes involved, and we'll have a few slides on those coming up. What we're going to be allowing are several telehealth codes. CMS is great about adding new telehealth codes every year, so always stay tuned to see if those meet your practice needs, and of course furnished by that eligible physician or practitioner. That originating site, of course, is that zip code, and then of course the coding eligibility, meaning you still, even though it's telehealth, you still follow all the coding requirements, regulations, information, if there's policies about the coding. For example, and this is kind of jumping ahead, is if you're seeing a patient for a telehealth E&M, once every 3 days you have to see them in person, or once every 3 times. So it's not, you can't have an E&M visit, evaluation and management office visit all the time to be telehealth in Medicare. So again, I'm digressing there. Now the equipment that we want to look at is HIPAA compliant, not emails, not over the phone or faxes. There has to be some kind of a program that meets the Code of Federal Regulations, or CFR 410.78. And you'll see here in these last sub-bullets how we talk about that equipment has to have two-way, real-time interactive communication. There are special requirements for the states of Alaska and Hawaii, but we're not going to discuss those today. You have to have that information. So let's look at the originating sites. And I think the biggest issue that some people have is, who is the originating? And that's why I put there in green, it's the beneficiary location. So now we're just going to speak about the beneficiary. So what they have to do is meet the rural zip code by following the Health Resources and Services Administration, HRSA. This is done through the U.S. Census Bureau, and they have to be housed at one of those areas, or it has to be outside of a metropolitan statistical area, MSA. So what I've done is given you in the last bullet how to click onto that data warehouse.
Sorry, accidentally in fixing this, our slide issue, we accidentally deleted number 14, which I have a printout here, which Lori will talk about it.
You bet, thank you. And so my next slide actually gives you some of those authorized sites, which include, the hospitals, and those include those critical access, the rural health clinics, the FQHCs, a skilled nursing facility, even a community mental health center, a walk-in retail health clinic. You can look at urgent care or a mobile unit. But what is not covered is the beneficiary's home, and that includes assisted living. So make sure that you're aware of that. And so this is that link where it would bring you to the HRSA data warehouse. We also utilize this in health professional shortage areas, in HIPSA areas. So we have, what you do is you type in the street address and the zip code, or you type in the whole thing, as you can see here in the bottom, and then you just click on search. So the next slide will give you these results. This particular patient was located in Aberdeen, Washington, which happens to be out in the rural HRSA area. So that means this patient qualifies. Now the next slide is going to give you someone that's not eligible. So you typed in an address for Seattle. Well, Seattle is not eligible. And so because they're not rural and they don't meet, and this particular address didn't meet MSA. So this is just an absolutely wonderful website. I love it. So before you even go any further, you want to check and make sure that that beneficiary is eligible or the place where they're going to be housed. Now we'll talk about distance site, and that means the practitioner. Oh. So, of course, they'd be providing those interactive services, and like Seema said, it might be their home as long as they've enrolled that way, especially if they're doing multiple states. They need to be contracted with every Medicare. If we're talking about Medicare only, every contractor in that state, because they're going to be paid differently. They won't be paid from their home. They'll be paid where that beneficiary is located. So the fee service will change. So they have to make sure that those 36 states, they're enrolled with all of those. And some of them might be the same, like I know Noridian has like 13 states. So again, interactive services, make sure it's a scope of practice of that particular provider. Of course, we've been asked over the years, can they provide telehealth without a state license? No. And then the medical decision making is always still the same as that face-to-face. And that's what I was talking a little earlier. You still need to follow what that code entails. And then the fee schedule is exactly the same as if you saw the patient in person. And so here's some of your eligible practitioners, which you can tell are your MDs, and that includes your DOs as well, and your mid-levels, also registered dietitians, nutritional professionals, etc. Now you do see under clinical psychologist and clinical social worker an asterisk, and here at the bottom I've shown you that they can only bill psychiatric exams that do not have office visits involved, evaluation and management. They are not allowed to telehealth or see in person any codes that happen to involve E&Ms. So this is an exclusion down here at the bottom for those two groups. And now we'll just go over some quick coverage and billing. A couple years ago, you used to have to append this modifier. You no longer have to do that in the Part B world. Now you're telling us that this code, because remember the codes don't change. You're telling us by putting place of service 02 for everyone, no matter where you're located, that this is a telehealth code. And that will help us in the case of if there's ever an audit, etc. Now it doesn't apply to the patient's originating site where they're located, because they have one HCPCS code that originating site will use. It's the only code, Q3014, without modifiers. And just go ahead and tell us what is that place of service. Is it an office? Is it a cause, an outpatient, whatever. And there is a national allowable. They get a stipend, as I call it, for $26.15 for the year 2019. And this is just for housing that patient for that hour or two visit. It just helps, offset those costs, because they shouldn't have to be doing anything. They shouldn't have to, they should just be able to take the patient to the room, confirm that is the patient, and then be able to leave and let the patient have a private conversation with their physician or specialist. And then, of course, the beneficiary is responsible for any unmet deductibles and coinsurance, just like as if they went in person. And so here's our E&M and consultations. As you all know, back in 2010, Medicare stopped consultations, but there's a couple in the telehealth world, so I found that always interesting. Critical care, be careful, make sure that you're following all those coding requirements. And here we have, I put it under mental health, behavior health. So quite a few codes are involved. We're not going to go over them individually, but if you want to talk about them later, we sure can. Then, oh, I love this, preventive and screenings. There are so many with that, including that annual wellness visit, which is something that a lot of providers provide. So, and then lastly, I just kind of grouped these miscellaneous telehealths together. There's a lung cancer screening that you can have a low-dose computed tomography, an LDCT. Well, you can't have the CT via telehealth, but you can certainly have the counseling visits. So there's also some chronic care management and advanced care and TCM. And now winding down, we have some resources where you can see our telehealth page, browse by topic, and there's also some internet-only manual information under 100-2 and 4. And then CMS also has its own dedicated telehealth website. And then lastly, before I turn it over to Craig, we have a CMS Medicare Learning Network booklet that has, under this link, that is a wealth of information, kind of covers what we just did in a different format. It's about 12 pages, and the January 2019 is the most current. So with that, I'm going to turn it over to Seema.
Yeah, thank you, Laurie. That was very information. I'm sure our attendees can use those information. Before I give to our next speaker, Craig, I want to clarify that what Laurie presented here is very specific for the fee-for-service population. If you have patient with a lot more commercial insurance, there is a lot more flexibility in how and where you see your patients. So please check with your payers. The most common CPT codes among the commercial payers I have seen is 99213 to 99214. And there are several questions regarding level of services. Can we do level service 3? So those are the things which you might want to figure out with your coders, payers, providers, and with the whole team. Next thing is marketing to your patients. How do you even start? Where do you even start? Craig and Annie will go into detail, but at a very high level, in-office promotion, using your patient portal to send the information, browsers, office educations, those are very important things to consider. Craig, next, it's all yours. I will change this, okay.
Hi there, can everybody hear me?
Yes.
Okay, thanks for having us in. Centerlogic and Annie and I have, we've both been in the healthcare industry. I've been in it for 16 years, Annie's been in it for over 10 years. We work with practices throughout the Pacific Northwest and really throughout the nation. A lot of what we do is working with small practices and help them with initiatives and goals as far as technology and security, such as virtual health. Small practices don't have the resources like large hospital systems or even very large practices. So taking on something like virtual health and all the options in technology and to get started can cost a lot of money, and the worst outcome possible would be to spend a lot of money and come out and not have it utilized very well, or just have it fail. So with that, we have, can you go ahead and select the next slide for me? Thank you. So with that, we've come up with some small practice goals and some small practice solutions. We have identified, 4 really keys that will help with any project really, but as far as virtual health and being successful, there's key things that we want to talk through to be successful. So one of those is security, and the other one's compliance to start. Any initiative that you start, whether it be virtual health or any patient portals or any of those things, security and compliance have to be your one and number two things to look at. You have responsibilities. You have people that want your data. You have people that want to exploit your vulnerabilities and things like that. So any service or process that you add through, you have to make sure that you're going through your processes, that you have a security process and you have a compliance process to do those things. The other things that we'll kind of talk about is engaging your stakeholders. So once you decide to do virtual health or you're looking at it, engaging your stakeholders and getting the proper people early on to engage in the product. And then 4, we're going to discuss what expectations we had, in our experience, what expectations did we have and what expectations did we follow through with, and, what were some of the end results. So we can go ahead and go to the next slide. So the next one is security first. So as I mentioned, we always start with security. The most important thing is, protecting your patients and protecting yourself. Your information is a very valuable target. Attackers aren't going to go anywhere, and adding services like virtual health can be another vulnerability that are available for them to exploit. So again, you're going to want to protect yourself, and you're going to want to put security first. With virtual health specifically, there's options to chat, there's options for video, there's so many platforms. I think they mentioned Skype, and I've had people talk about FaceTime, and insurances cover some things. HIPAA, some stuff isn't even HIPAA compliant. So you really need to do your homework and seek advice if you don't have the resources to answer those questions. But the most important thing is just don't go in and decide to do something without doing your homework and going through your process. So the first thing is have a plan and be prepared. So as far as security, you always need to identify what do we have that needs protected. Your patient information is one thing, but insurance information, you have third-party risks that are involved. I know, you have labs and other things that have your data as well. So knowing what's happening with your patient information and where it's being stored. If you're doing virtual health, the third-party person that you have providing those services, are they protecting you? Are you protected through them? Or are they providing any risks for you? So identify those things. And then also, who is going to protect us? So you're responsible for your protection, but all the services and things that you use need protecting as well. So what resources do you have if you're not sure? Do you have lined up consultants or security experts if there is a breach? Do you have somebody that's going to help protect you and help stand up with you when needed most? And then next is, how are we going to keep our infrastructure safe? So as you add on things like virtual health and portals, and again, it goes through tons of different technologies. A foundation is most important to be able to answer those questions. So you have an infrastructure, you have a bunch of services, you have a bunch of data. How are you protecting that? You need to identify those, and those things need to be identified and worked through before you start any product like virtual health and processes like that. Because if you start something like virtual health and you have doctors meeting with patients virtually and exchanging information and data, you have to know what's going on with that information and with those conversations, and make sure that you're limiting your risk. So what we usually do, and what I always recommend for the people that we work with, is every infrastructure has many forms of access and vulnerabilities. Adding virtual health is another way of providing access to your practice for convenience for patients, but it's also another way for attackers or people with malicious intentions to expose vulnerabilities. So please seek guidance from a security professional. They can help you identify and help your organizational layer your technologies and provide steps to secure every layer within your network. The other thing is monitor, detect, and respond. So it's important with all your services that you provide that you're able to monitor what they're doing. You're able to monitor the tool. You have tools in place to monitor when things get busy, things get out of control. You have processes in place that can flag you when something isn't right, or if people are trying to attack you, you have devices that'll alert you. All these things are very important, even if you're storing data, even if you're not doing virtual health. But every time you come up and say, hey, I'm thinking about doing virtual health, it's important to review these processes and review these items to make sure that before you start on and add virtual health or adding a new service, that you have these things dialed in, and all your stakeholders and all your key people that are involved in this process know what those requirements are. If there's a breach or there's a vulnerability, all those key players are going to be the ones responsible for answering questions and mitigating your issues. So act promptly, have a plan, and move forward. So the other thing that is important is compliance. So everybody knows HIPAA compliance, and we have to follow HIPAA, but do have you identified what those responsibilities are? Do you have a plan? So compliance, again, you're adding something new, you're looking at adding another key player, another service in virtual health. How does that fit into what your current HIPAA procedures are, what your current security responsibilities are? If you review those and go through and, it breaks any of your identified policies, or it counters any policies or procedures that you set up, or put a wrench into what you have, you're going to need to address those, and you want to do it before you go live and before you implement something like that. And so once you have a security plan and you have that foundation that you're building on, when you add services and things like that, you have a plan, you're following it, you're reviewing it. Those are key things. The worst thing you can do is have a plan. So we're gonna start virtual health. We have a security plan. By starting virtual health, and say you're chatting PHI through a Zoom virtual health session, and you have an internal policy where you're not allowed to transmit PHI other than through secure email or encrypted sessions, and you haven't identified that, and you're doing chatting or you're exchanging data or PHI information from a different platform. If there was a breach on that and you broke your own policies, they're more strict on you. It's worse to break your own policies that you have put in place and you did not follow them. So you really have to identify what your policies are, make sure that they fit in line, and make adjustments as needed. So with that, knowing your risk, this is an important thing. So when we come on and we have providers and we have administrators saying, we really want to look at virtual health, we want to look at what virtual health will do for us, we want to set this up. So the very first question we have is, us IT people and our security departments have to know, what's our risk by doing this? We're going to need to consult these administrators. We're going to consult the providers that are going to be doing this. We need to know what our risk is so that we can limit it and make sure that we're following compliant resources and that we're using the right tools to be successful. Number 4, so get help, know your resources, establish early on who's going to help you with your security questions, who's going to help you through this process, who's going to help you with the workflows, who's going to help with training, and make sure they all have the same message, they all have the same security and compliance data to follow those recommendations and to train all your users to follow them. And with compliance is audit, review, and assess. Schedule reoccurring times to audit, review, and assess your procedures. This should happen at minimum a yearly basis, but when you implement something like virtual health or you implement a new service, you are supposed to review your processes to make sure it aligns in. Anytime there's a major change to your infrastructure, anytime there's a change to what your processes are, you're supposed to review those again to make sure that they align. Things change over time, technology, staff, laws, all those things require a review when they change. So ensure you review your procedures and policies when recommended. Next, Annie's going to kind of talk about the process through what we went through with a few of our customer bases and what we kind of struggled with, and kind of walk you through the process we went through when we set a process up for customers.
Thanks, Craig. So kind of the first piece is identifying your team. Make sure you're thinking about, when you're doing this implementation, not just providers and administrators, but also thinking about, from a patient's perspective, who are the team members that are needing to know these processes, who are speaking to the patients, who's scheduling these appointments, to make sure you're thinking about RNs, triage staff, if there's a layer between when they're actually scheduled and when they're seeing the providers, schedulers, of course, billing staff, making sure you're going through who needs to bill and what codes need to be billed. I know we went over that previously in the slides, but we have a lot of commercial insurance companies that have different codes that need to be looked at. And just making sure that these users not only are wanting the workflow processes in the beginning, but also are helping with your training once you go live and implement. These are resources that other users within your staff can identify to go to when they have questions about either the technology or just the workflows in general. Also, as you're looking at the different technologies, as Craig mentioned, wanting to look at the security and compliance, but also there's a lot of telehealth options out there. So looking at how much is this really going to cost? Do any of these services offer you any kind of demo or option where you could set up the service within and let you trial it before doing a full implementation? That way you can kind of test out how worth it's going to be for your practice. And then when you're looking at workflows and processes, standardizing all processes as much as possible, this is going to make it so much simpler, not only for your users, but really for your patients. The last thing you want to do is make it complicated for your patients to use or your staff. And when we looked at this, we really tried to identify what do our practices really need. So answering some key questions. So which providers are even going to offer these telehealth visits? Of those, what types of appointments are appropriate for this? Are the durations going to change if you're seeing this patient through telehealth versus in the office? How are you going to identify these patients in your schedule? So when they're coming in, you're not expecting them to walk through their door. You know that this is a telehealth visit, so there's no communication breakdown, and you're not wasting time waiting for them to show up when a provider is really needing to get logged into that other technology system. Another piece is billing considerations. If this patient is expected to pay a copay before they're seen, how are you going to collect that copay? How are you going to make sure the documentation is accurate in your EMR? So if the providers are required to document these services in a certain way in the visit, making sure that you have those set up. And then just further considerations, thinking about how are you going to let your market know that you're identifying this, like letting your patients know through emails or through services on your website, making sure you're reaching out to your patients and letting them know these services are even out there. And then if you want to go ahead and go to the next slide. Setting up expectations and what to expect. So we have lots of different ideas out there, providers that are really gung-ho and want to see all of their patients like this. Some providers that are not as comfortable, and same with patients, just patients that are really not ready for this type of technology. Making sure that you're reaching out to your partners, if you have identified patient partners, helping them, helping you kind of identify them and keeping them in the process as well. Are you ready for these kinds of items, and are your patients ready? So I would say if you do have any type of platform, lots of clinics have after visit summaries or surveys that they offer their patients. If you have access to manipulate those surveys and asking a question like that, we had patients or partners that were really excited about this solution, but then after we implemented and we went back and asked them, they actually didn't utilize the service. So really making sure that you have a large population that you're surveying to kind of help identify if this is a service that you would really use.
And that's one of the important questions to ask in what we had found is, you know, in pediatrics, for example, a lot of the parents are younger people, so we were very encouraged, oh, they'll get on, they'll use virtual health, they'll do all these things, but it was just slow to adopt. So one of my biggest points is don't go out and invest in a bunch of software and processes and get this up if your patients aren't going to take advantage of it. Know the answer to that. And then also know the answer internally. Even if your patients are excited about it, if you have nursing staff or you have scheduling staff that aren't encouraged to do this or struggle with providing the service, then they're not going to be able to have the tools or the energy to offer this to patients in the first place to get them on the schedule. So that's a large portion of just making sure you're ready. A lot of clinics and a lot of hospital systems out there, they have a lot of the resources to just, oh, we're going to go out and get this really expensive virtual health platform, invest a lot of money into it, and they have the resources to make it work. And even if it's slow to adopt, they can continue using it even though it's pouring out resources. Smaller clinics, they need to be more careful. They need to find a way to make sure this service is going to benefit them. And another big thing to consider, and every practice has to answer this question for themselves, is how much time are we putting into this early versus how much are we getting paid back? So we're doing a virtual health visit, you know, is my doctor spending more time trying to get connected and working with the patient? And then are my billers spending a bunch of time trying to get reimbursed? And then are the schedulers spending more time trying to get this set up to whereas you have one visit and the amount of money you get back for that visit isn't worth providing the service. So you'll need to answer those questions and before you even get started or before you even invest a lot. So that's a key message we have is we started small. We were able to use a demo. We were able to get a process and a workflow at one of the major clinics, and it turned out the patients weren't ready to use it. They didn't want to adopt it. We set some base visits for just like rashes, to be able to identify rashes and things like that. Just very simple visits where they didn't have to come in, and you know, they just weren't ready. They're not prepared, and they would rather follow the same process. So some of that stuff will have to change over time. We're not that specific clinic isn't giving up, but you know, they're just taking their time and preparing their staff and their patients because we're pretty convinced it's not going away. It's just right now it's not the time to go all in and spend a bunch of money. Now it's the time to do it slow and prepare our patients, and then when we feel like it would really be utilized, we'll jump forward even more and invest in those technologies. And other clinics that I've worked with, it is working great. So just know those answers for yourself. And with that, I think we can go ahead and turn it over and do some questions and answers.
Yeah, sure. Thanks, Craig and Annie. That was a wonderful presentation. We are ready for some questions and answers. You can mute yourself if you would like to speak, or you can type your questions.
Yeah, we have two questions we can read in chat first. So again, as Seema said, after we review the chat questions, then we can move forward to any audio. So if you can then unmute yourself after we review the two chat ones. So the first one is, will the slides be shared with us?
Yes, slides will be shared with you all.
Okay. So the second question is, when you say originating site, does this refer to the party making an outgoing call to begin the telehealth encounter?
Lori, you would like to take the question?
Yeah. No, that's where the beneficiary is housed.
Would they like to speak?
So this is from Eric Chen. Eric Chen, did that answer your question? You can unmute yourself, or if you want some clarification, you're welcome to ask that.
Hi, Eric. This is Lori from Noridian. If you look back, or maybe we can go back to slide 14, I'm not sure if they'll go back. You will see a listing of those originating sites, and that the beneficiary's home or an assisted living is not authorized for Medicare Part B fee-for-service. I'm not speaking to telemedicine as a general for managed care and for commercial, etc. Does that help?
You can either chat it. Oh yeah, he said, okay, slide 14 was the one that was missing before. Yes, it helps.
And now it's on the screen.
And somehow
Technology.
up here.
I love it.
Yeah.
Okay, so there's one more. It's a comment and a question in there. So it's from Elisa Scherzinger. Hopefully I pronounced it correctly. It's sorry, long question. When billing coding for an EM, one of the main components to consider is the physical exam. Obviously, telehealth presents a bit of a challenge with this. Will this require down coding? What if the patients are providing the results and/or we use peripherals? Any recommendations for peripherals or apps that can help provide vital signs?
And I think I can take that, Lori from Noridian. I don't know if you heard me, I kind of alluded to the E&Ms in the beginning. This is something that you need to really look at because there's very specific requirements for the E&M, and I believe you have to see the patient face-to-face at least once every 3 times that you have telehealth. So they're already expecting you, or CMS is expecting you to have a lot of that information of the physical exam, and that you're just doing some of the follow-up in telehealth. Does that help?
So what
And
Lori
this is Craig from Centerlogic. I can just add one thing. As far as the tools and apps that are available, it's a newer technology, but they do have tools and apps for virtual health that can get vital signs. Talking to your EMR vendor, talking to other professionals in the industry, and just searching. They do have apps that can get vital signs, but again, you got to make sure you'll get paid for it on the billing side. But I don't have any off the top of my head, and we can probably send out an email or something with some examples, but just going out and getting an app or a tool, it's got to be able to fit with your workflow and your EMR and things like that. So there are tools out there, but consulting with whatever EMR you have would probably be my first step. And then if you do research or you do come across something you could just Google finding a tool for getting vital signs through telehealth, and you'll most likely find a few services that provide that. So you'll just need to make sure, one, you get reimbursed and it fits your billing requirements, or if it's a cash-only visit, if it fits in with your workflow with your EMR.
Okay, thank you, Craig. So we have 2 more questions in chat that we'll take, and then we'll see if there's anyone who wants to verbally ask a question. And if there's not anybody, then we'll go back to chat if there's any new questions. So the next question is from Eric Chen. Is that requirement of once every 3 times necessarily with the same clinician, or is it one in-person visit at the clinic with any clinician?
I think it would be with the same clinic. It would be any physician. Anywhere where you can share your EMR records. However, Eric, if you want that much detail, I would be happy to either have you email me direct, or I can get that information to Seema to share.
So Eric, you have my, the last slide has my contact information. Please send me all the questions and I can work with Lori on those questions and email you back.
Perfect. And the final one is from Elisa. And it's, can RNs bill for the AWVs? They were not listed as a covered provider. They can do this in the clinic setting.
Correct. And that is something that I don't have the answer right now, but I actually proposed that question because you should be able to follow just like it was an in-person visit. However, I'm not aware of telehealth having an institute place. So I'm gonna have to get back to Seema on that one and check with our medical directors, because that is a big question and I think it's a great question. Thank you.
Okay. So it doesn't sound like there's anybody who has anything, who wants to ask any questions via audio. So, and I don't see any new chat questions at the moment, but if anything comes up afterwards, you can email Seema and I'll pass it on to her.
Yeah, so please email me as many questions as you can and as you would like to. I will work with Lori, we'll come up with kind of frequently asked question, kind of documented. We'll email you all. And if you don't have any more questions, we would like to thank everyone for participating. This was our first attempt on getting telehealth out there in the community. Feel free to contact us at any time. Thank you again.
Thanks, everyone.
Thank you.
Thank you. Bye-bye.